Okay, thank you very much for this kind invitation to be here in this very interesting meeting. So I'm going to, without any other delay, to present the case. The case is a 79-year-old male, hypertension and hyperlipidemic. He has an episode of atrial fibrillation some months ago, and he underwent electrocardioversion, and he presents in our hospital with angina on effort, with normal LV function and a mild aortic valve stenosis. So this is medication, and this is his coronary angiogram. You can appreciate an, let's say, intermediate left main lesion, a circ which is atherosclerotic but no significant lesions, and tight mid-LAD lesion, and the CTO and a total occlusion of the right coronary artery. This is the images of the patient. His syntax score, assuming that the left main is significant, is 25, and he has a low surgical, low operational risk STS score and Euro score for surgery. So to start the discussion, I'll put some questions. First, you think this left main lesion is significant? Second, is this patient for PCI or for CABG because he has a 25 syntax score? If we decide PCI, what would be our strategy? Which vessel we will start? Or if we need further estimation, especially for the left main, how would you proceed? Physiology, imaging, what? So I will stop here.
Start the discussion. Professor Skalidis, you have a bias coming from the same center, but what is your opinion? What would you do?
Yes, but I don't know the case. Just to ask, the ejection fraction was normal?
Yeah, a normal ejection fraction and a mild aortic valve stenosis with a gradient of 22.
Let's let the angiogram play for the control room. Let's let the angiogram play.
Yeah. Can we go back to see the angio? No.
And is he diabetic?
No, he's not diabetic. He's hypertensive, has an episode of atrial fibrillation. He's on anticoagulants, yeah, apixaban.
So,
yeah. You want the still images or the...
The angio is better.
Yeah.
So we have a significant lesion in the LAD and the immediate lesion in the left main and total occlusion of the right coronary artery that is somehow difficult to recanalize. No, it's easy to recanalize. So if this is the left main is significant, I think that this is a case for CABG. If not, then it's for PCI. The main question is how to assess the left main. And one way is to go through to the left circumflex and assess the lesion. The other way is to open the LAD and after assess the left main with FFR. Or with a CT, maybe. The CT may show that the significant...
So let's ask the two cardiac surgeons, Professor Angouras and Dr. Pattakos. Would you take this patient for CABG? Do you need more information? What's your opinion?
This is a CABG patient. And
not very ambiguous.
But still, I can explain you why. Why are you?
Dimitris, this is an interventional cardiologist.
I know, but the truth has to prevail. You know,
but in the right coronary artery is not.
The right coronary artery. I don't know whether you'll be able to fix it or not. Even if you fix it, what you won't be able to do is probably put a clip at the left atrial appendage, as I will do. So I will decrease this patient's stroke rate by 33%. This is one of the advantages you probably did not think at all. So before I take a decision, though, I would like to have an IVUS of his left main, not an FFR especially because this guy has distal stenosis, so the FFR probably will underestimate the significance of the stenosis. But if its MLA is below 6 millimeters, I will do a Kafkas ×3 plus a clip to his left atrial appendage. That's what I would do. If not, if the MLA is not very low, I would do limited LAD, probably a vein to the or a radial artery to the PDA and a clip to the left atrial appendage.
Because what is your view? And then Tom, I have a question for you.
I'll be brief. I think we really need to realize the other thing nobody is discussing, and I'm sure you're going to say it's non-significant. Look at that first obtuse marginal. If it's not diseased now, I think it's going to be diseased at some point in the future at that first bend. You're calling it non-significant now, I'm sure, correct? But at some point, that's going to also become significant. The other thing you have to look at is that this is potentially, if that first OM becomes significant, this is a patient who has left main disease and triple vessel disease. How many indications for surgery do we need? Does he also need to be diabetic and low ejection fraction for us to operate on him? So I think we're getting to the point where we have multiple indications that this is going to be better. And I think the other thing that an interventional cardiologist should discuss with his patient is what is his likelihood of needing a repeat procedure in the future? Right, so let's say you can get away with stenting this patient today, and he's going to be okay today, and you put 27 stents in the RCA and maybe 1 or 2 in the left main, and then you do the LAD.
He's 80 years old.
He's 80 years old, right? But in general, right, he's 80 years old. But in general, we see a lot of cases. We had a lady. Everybody says he's 80 years old. We had a lady. We put a TAVR in at age 86. And she came back at age 92. So don't think that just because they're 80 years old, they're not going to come back to their office. And then maybe they'll be referred then for CABG when they're 85 or 90. But we really want to see what's going to have the best long-term results. And every cardiology conference, Dr. Angouras and I, we sit and we chat. We would like to know, we know the patency of our mammary, we know the patency of our radial, and we know the patency of our saphenous vein graft. I want to know, what is the patency going to be when you stent that RCA, or what's the patency going to be when you stent the LAD? I would like some specifics, and I know that it's stent dependent.
Let's see what someone would do in another country. Tom, what would you do in the UK?
This would be a PCI case all day. Genuinely, and I'll tell you for why. So the first thing to say is the patency by stents of this RCA is vastly superior to a vein graft on it. Vein graft on that will last... Well, we know that 50% of vein grafts to the right will be gone at 1 year. So we will have better patency than that, I can promise you that much.
50%?
This isn't a CTO. There's a little way through here. The distal vesta is fantastic. You're going to end up with about 60, 70 millimeters of stent. But if it's all IVUS optimized, beautifully pre-dilated, and you get sizes of 3.5, 4 millimeters in that right, this right vessel will do extremely well. The other thing against surgery for me is that a lemur on the LAD, fantastic operation, it will last forever. But if you get progression of that disease in the mid-LAD, which you will, your backfilling won't go up to any of those big septals, diagonals, and everything else. So that doesn't help you either. And your vein graft on the OM will go down before 1 year. There's no argument. So you put an 80-year-old with a normal LV and no diabetes and mild aortic stenosis through an operation with the risk of stroke, which is not small, and essentially you give them a lemur to a mid-LAD in the long term. So I wouldn't do any of that. I'm a very conservative interventionist in the UK, and that's what I think. The left main looks as if it's like a sort of calcified nodule. So it doesn't, in any view to me, look as if it's going to be physiologically significant. I'm happy to be wrong. I'm happy to have other assessments to understand it better. But I think, again, we have to be pragmatic. Prognosis is irrelevant to an 80-year-old. So we've just got to make him feel better and give him the best long-term outcome that we can. So personally, I would take on the right coronary artery with a complex operator and get a great result. And at the end of that, if that went really well, I think the LAD should be relatively straightforward.
Because
10 seconds
counter. We'll have more time for discussion. Let's hear also the Italian perspective. There's also a question about the left main, which I agree with Tom. It's not clear what's happening.
Is less extreme. I can understand your position. I can understand the position of Tom. I think that the essence is to get a full interrogation of this vessel imaging is crucial. It doesn't matter if you're talking about a non-invasive. In this case, I think invasive and the best that we can in terms of measurements is going to be essential. So I think that is the crucial point. And for the remaining, I can take your view. The distal anastomosis is very good for LAD, possibly good also for the right, but probably the right is going to receive a vein and not a full artery revascularization. If it's going to be a left radial artery, perhaps the results are not going to be the same. So I think that now the point is how to evaluate this case. And for the marginal branch, I don't think that based upon this data, you can anticipate the future and going to revascularize at this point also the marginal.
Let's hear also the, thank you, Julie. Let's hear the Belgian perspective from Panos Xaplateris.
I think, Professor, I think that there are, first of all, we have to estimate the left main coronary artery for two directions, to LCH and LAD, but there are two reasons to go for surgery. One is if the right coronary artery is craftable, and the other one is to close the appendages because the patient is 79 years old. It is very, very crucial for these patients to avoid antithrombotic therapy.
Okay, thank you. We'll have more time to discuss about the case when Michalis saw what happened. We'll have more time to discuss about whether that was the right treatment. Let's hear from Panos, and then Michalis will show us how he treated this case, and then we'll have time to discuss.
So in my center, this would be a case for hybrid. So we would start with CTO PCI of the right, and then we would refer the patient to the surgeons to put lima to the LAD, mid-cab. Regarding the closure of the LA appendage, the only trial that has looked into that is the LAUS 3 trial, where patients had their appendage clipped, but they continued taking anticoagulants, and this is something that's true to keep in mind.
A solution in the middle. Let's see what happened, and then we'll...
Very interesting comments and different points of view. That was the main point. So we discussed with this patient both options. One option was, of course, surgery, and the second option was PCI with estimation of the left main, starting from the CTO of the right coronary artery. The patient was 80 years old. He didn't discuss surgery, so we decided to go on percutaneously. I like physiology. I'm a little bit biased with that. Of course, imaging is of paramount importance in this case, but I thought that I should estimate left main with physiology and LAD together. To do that, it's crucial to open first the right coronary artery, to have the area that is real for the left main, because otherwise you have also the right coronary artery area and you don't get the good results. So we started with a quite easy procedure. This was actually a functional CTO, I would say, with a filter XT and predilatation and 4 mm or 0 stent. We had this, which I consider a good result. So we stopped there, and then the patient came 2 weeks later to see what we would do for the left coronary system. So this is the image. There is a system from Volcano Philips, the co-registration, IFR co-registration, which is very nice. You can take angiographic images and together see the IFR pullback, which is superimposed on the angiographic image, and then you can locate exactly what is the significance of the coronary lesions. So our initial plan was to go with a wire in the distal LAD and then perform a pullback and see what was the significance of the LAD in the left main. So by putting the wire, the patient started to feel chest pain, so we decided to go with a direct stent in the mid-LAD, with a good result. And then, after some minutes, patient was okay. We went on and did an IFR estimation. You can appreciate the dots. Each dot represents a delta 0.01 IFR value. And you can appreciate that the IFR distal was 0.84, and for this, the responsible was the left main. So decided to go on with PCI of the left main. Of course, when you do PCI of the left main, you have to use imaging. Otherwise, it's not a good option. So we did an IVUS to see the left main, and by doing the IVUS, we thought, okay, let's measure also the MLA of this tight left main lesion. So the tightest diameter, the MLA that we could measure was 6.3. We couldn't go below 6. And now we have a discrepancy. We have an IFR, which shows significant left main, and we see IVUS with borderline MLA.
Stop here for a second. Anyone from the panel that has an opinion on how to proceed from here? So we have IFR of 84, positive, and MLA of 6.3. Dr. Kafkas, yes, what would you do?
Personally speaking, I use for left main disease, I prefer imaging. And I trust eyes with by imaging, not IFR.
You would stop here then?
Yes.
Okay.
Yes.
Any other opinion?
And I think that from the beginning, in the modern area of PCI, I think it was easy to fix the RCA, as Michalis do, and LAD is an easy lesion. The question was from the beginning, what happens in left main? And the answer is the IVUS, I think.
Professor Galliumi, at this stage, you think an OCT for the left main would be useful?
Well, let's discuss about the images that we have in front. Resolution. You can trace the border, but you can be 2 millimeters in or out. Is by the chance. That is low resolution IVUS. That is important to be said. So the precision in terms of lumen is not comparable between OCT and IVUS in the low generation, in the low, the low frequency. The second point is, beside the lumen, you have the plaque burden. Very important. You can see how much you have on the opposite side. And that is important to get the media very well detected and to make the calculation of the plaque burden. If you have a marginal value, means value at the threshold that normally you are deciding if yes or not, the plaque burden is going to be extremely important to take the decision. And here, in my view, the plaque burden is very, very relevant.
I'm very happy that I see so much interactions. Michalis, before coming to you, because Grigori is asking, Grigori, now that you know that the left main might not be significant, would that change your opinion about surgery from the start?
Before I answer your question, if you would allow me, as a naive cardiac surgeon who is not a guru in IVUS or physiology or anything, I would ask you the following. When you set a cutoff for your area with IVUS, and you think about the fact that you may have a grandmother from a Greek village with a height of 1.30 meters versus an NBA player with 2.20 meters, you know, it's the same as what I'm trying to get your mind to go to is, we say that for surgery now you need an aneurysm size of 5 centimeters. It's different based on the patient's size, so maybe this needs to be indexed to something.
So this is a critical point, because it cannot be used as binary. It's not the same for everyone. That's a very good point.
Should we index it? So me, and as my naivete, I'm not a specialist in intravascular imaging, obviously, although we do use IVUS in the thoracic aorta for our endovascular cases. But it would seem to me that physiology is much more important here when you're talking about flow than simply measuring the size of a lumen. And so as we, you know, proceeded to say maybe the IVUS is going to show you plaque, maybe it's going to show you other things that give you information, but perhaps physiology should trump things, especially when you're saying that maybe we got the wrong cross-section, maybe we're not measuring it appropriately. All of these things are a little bit user-dependent when you're doing things like IVUS. Now, for your question about the left main, if you take the left main out of the question, then it becomes, essentially you're telling me it's a two-vessel disease case in an 80-year-old, correct? So I think that does change things somewhat, yes.
Okay, good. Michalis, your question or comment?
You talk about the discrepancy and you have dilemmas, but to my eyes, both modalities show the same thing, because if you go back to the IFR, please go back, your value is not 0.84. Because if you count out the points that you have up to the ostium of the lady, you have 4 points there, 4 bullets. So if you go up to the ostium of the lady...
It's not the ostium, Michalis, all this is the left main. You can see the ostium is even further. So
let's see what Michalis did, and we'll finish with the discussion. Grigoris, I'm sorry, let's see what Michalis did, and then we'll have more time, because we're running out of time.
It's only a short... Michalis, congratulations on all the discussions. I have to say only that we translate things in the wrong way, because we discuss for a physiology measurement after PCI. We don't have data regarding that. We know that what is the best value if we have a naive atherosclerotic lesion there, but we don't know exactly what to do when we take physiology measurements after we change the shear stress of the stented area. We change all the things we know, and we think that post-PCI values are the same with the pre-PCI values.
Okay. I will agree with most of the comments, and especially Dr. Guagliumi. Of course, the discrepancy, the image is not, quality is not fantastic. What Grigoris said is that 6 square millimeter is something that was validated against FFR. So 6 square millimeters is a cutoff value which is not for everything and everyone. And of course, what Grigoris said is very important, because when you do post-PCI physiology measurements, especially with IFR, which is a non-hyperemic index, you have to be sure that you have no hyperemia. So you have PCI, you have hyperemia from the PCI, and then you have to wait a lot with IFR, and sometimes this is not always the best.
Okay, let's see what happened.
Yeah, but I'm trying to explain, because what I did is what I know is FFR. Yeah, because
I have to interrupt you.
That's why I was pushing for it.
What I trust more.
I knew that. I wanted to say
in the US, you know, they say when you don't know what to do what you know.
Yeah. So I did FFR. I found the FFR, which is 0.76, and I went on with a stent crossover, left main LAD, 4.5, kissing and pot. This is the final IVUS with a good stent apposition and a good final angiographic image. And to finalize the case, the main message for me is don't forget you use your clinical judgment beyond all the imaging and physiology methods. Thank you very much.
Any questions or yes, Yosif?
Finally, he could have been a cabbage candidate, right? With left main and 2 vessel disease. So I think that we owe an answer to Dr. Pattakos about stent failure rates, right? So after the first year, it is well known. I would say if somebody want to disagree with me, actually that's the number. The stent failure per year is 1.5%.
Per year.
For year after the first year, right? So during the first year, it's a bit higher. So in my opinion, what numbers say that the new technology stents are much better than vein grafts. However, it seems that still Lima is invincible. That's I think that it's honest.
This is true.
For this 80 years old man, you don't expect any stent
failure
in the next 5 years. Any questions,
Well, this dogma, the new stent is better, is something that I've been hearing since I was a student, and this is true. The stents are getting better, but I think they will never get better than an arterial graft to the coronary artery for several reasons. I'm not going to explain all of that, and that's what I think FAME 3 already showed, right? You went with not third, but a second generation stent using FFR and everything, or we just operated on just based on angiographic estimation of lesions, and still, you know, the composite endpoint death, MI, stroke, repeated vascularization was significantly better with a hazard rate of 1.5 at 1 year already.
Okay,
can I make a quick point? 10 seconds.
We can do it after.
No problem. We'll do it next.
Case also has a lot of discussion points between cardiac surgeons and interventional cardiologists. I will ask Simone Biscaglia to give his talk, which is relevant to this case.